All right, let's get started. I'm Jenny Mason, and I'll be hosting today's webinar. We're concluding our three-part webinar series with today's presentation, and if you were on the previous two webinars, you'll be familiar with Jared Jones, Partner and Hospital Practice Leader for Partners in Leadership. I'm pleased to introduce Russ Hill, Director with Partners in Leadership, and welcome him to this webinar series. Jared and Russ have both worked extensively with some of the largest for-profit, nonprofit, and faith-based hospital systems in America. They come with extensive experience in the hospital industry, including helping to achieve dramatic shifts in HCAHPS scores, staff and physician engagement levels, and other core measures. I'm glad to see we have a large group of participants on today, and I'm looking forward to your questions for Jared and Russ. So please use the Q&A function on the right-hand side of your screen to submit your questions at any time during the presentation. Jared and Russ, let's get going.
Thanks, Jenny. Appreciate that. So, guys, today is going to be a very unscripted opportunity for us to share with you the experience that we've had in the last 27 years working with culture, accountability, and specifically in hospitals. We've got a very specific hospital team that works only with hospitals or largely with hospitals. And myself, I'm one of the leaders of that team. Russ is a key member of that team, a director on that team. And you're going to hear both of us share stories. You're going to have us share real examples from what we've experienced in working with hospitals and how we've applied the content that we're going to share with you today to help you see how to get better HCAHPS scores and look at that differently. We're passionate about what we do and what we're going to share with you, and we're passionate about it because we've seen the impact that it creates. So it's going to be a fairly organic call. We'd love your thoughts and questions at the end. So as Jenny mentioned, please send us those questions through the chat feature, and we'll address any of your thoughts and questions at the end of this call. Russ, why don't you take us through the 5-minute quick intro on the 3 tracks and how we organize our work?
Yeah, and Jared, as you said, our firm's been working with organizations across all different industries, and Jared and I spend most of our time, as he indicated, in hospitals across America. And our firm's been working with organizations on creating a culture of accountability for, well, we're coming up on 3 decades, 27 years. The book you see there on the left, associated with the self-track, the Oz principle, most of you might be familiar with that book. It came out more than 2 decades ago, and it's what really what most people associate with our firm. And the work we do with organizations is really divided into these 3 different lanes, if you will. And all of the work, no matter which lane it's associated with, is designed to do one thing, and that's to help organizations achieve the outcomes, the most important outcomes they're looking for, what we would call key results. And so each track is associated with a different New York Times bestseller book. On the left side of your screen there, you see the self-track, which is associated with the Oz principle. And the basis of that is, how do you hold individuals accountable? How do individuals hold themselves really accountable for what the organization's trying to achieve? How do they get above the line, and instead of looking somewhere else, looking externally for the solutions to the challenges that we're running up against, how do they look in the mirror? How do we get them to look in the mirror and find the solutions within themselves? So that's the self-track. And then there in the middle is Change the Culture, Change the Game, the book that's associated with the culture track. And the culture track is where you take organizations through a process of defining what culture we need in order to produce the results we're trying to achieve in a 3 to 5 year time frame. And so what we would tell you is that culture produces results, and we'll dive deeper into that during the course of this webinar today. And so culture, just basically defined, is the way people think and act. And so your culture today is perfectly aligned to produce the results you're currently getting. How do we know that? Because you're getting those results. The problem is that you want different results, and so there are higher HCAHPS scores that we want, and there's a higher level of employee engagement that we want. Most hospitals are dealing with retention issues of quality nurses. How do we hold on to them longer? How do we improve employee satisfaction scores, and how do we improve quality and safety inside our facility and impact the revenue and the financials in the way that we need to? And so culture produces results, and so today's culture, we would say, is C1. The culture we need is C2. C1 produces R1, that's today's culture, produces today's results. and the results we're trying to achieve are 2. You have to have, in order to achieve that, you need to have a C2. And then there on the right is the others track, and that's how did that happen is the title of the book that's associated with that, and the others track is all about how to hold other people accountable in a positive, principled way. Many of us who've spent more than a few seconds in the workforce have had an experience of being held accountable the wrong way, and so we know the negative outcomes of that. And so the others track's associated with holding people accountable in a positive and principled way.
So as we go into this further, we're going to do some polls throughout this webinar. And largely the polls that we want to do, we want to make sure that we're using our time most effectively and your time most effectively. And these help us really direct where we're going to go with with some of our comments and some of what we share. So we'd love to get a feel for who's on the webinar today. So if you're in a group, by the way, if you can just get aligned as a group as to if you're in a conference room, for example, and you're there with other people, just get aligned in how you want to answer these questions. But check all the boxes that apply here. So the first one is, what's your purpose in joining today's webinar? The first one is, this is my first webinar with Partners in Leadership, and I'm interested in the topic. That's why I'm here. The second one, I was on the last webinar and wanted to learn additional tools. The third, I was on a previous webinar and have invited others to attend with me today. And the fourth, someone I know attended a previous webinar and they invited me to attend today. Let's go ahead and just take a minute, select all those that apply. We'll give you just a second to answer, and then we'll see what we've got for who we have on the call today. Group, as we go into this today, we're going to get into some very specific topics, and based on actually, Jenny, are we getting the responses there? So 68% of us on this is the first webinar, and you're interested in this topic. 21%, so almost the vast majority of us are there, but 21% were on the last one. So we'll try to balance what we do with introducing some of the things that we introduced on the last webinar or two, with giving you some additional tools today. We've got a plan to go into some of those models a little bit deeper than we introduced on the last call, but didn't go in as deep, so we're going to take those deeper today. I think that'll work with the mix that we've got here as well. So one other webinar poll that we want to do is this one. When working to improve HCAP scores, where do we spend most of our time, strategy or culture? If you look at the strategy bucket is the action plans, the procedures, the way that we go about changing behavior, nuts and bolts, getting people to do things differently, structural, strategy, action layer stuff. Culture is how do we think, how do we act, do we get people thinking and acting the right way, and that really gets into the culture of your organization. So where do we spend most of our time? Go ahead and align on where you think that answer would land for you. Second one, which has the most impact on our HCAP scores out of those two answers, strategy or culture? And just go ahead and mark the one that you would answer out of those two. And then we'll get the numbers here and show you what we've got. We've done this poll on the last 3 or 4 calls, and it's been interesting to see the correlations between all of them. We're going to show you some of the data here in a minute that we've accumulated from some of these other and other research that we've done as well. We'd like to see where you're landing on that on this call as well. So Jenny, let's go ahead and close that and get our answers from that. Okay, so this lines up really closely. You guys are saying 67% we're saying that we work on strategy versus culture. And that's totally common. We're seeing that. Here's what we see from all the other research that we've done. We find that 74% are saying that. You guys said 67 on this call, so we're right on line. And then 96% is what we're finding are saying with the most impacts, our culture is impacting our HCAP scores more than anything else. And to that point, if you think about the organizations that we hold up as the gold standards, the Cleveland Clinics, the Mayos, the others, right? If you think about the impact of their culture on HCAP scores, we're trying to pull out the best practices from these organizations that are doing it well. What we often aren't taking into consideration is that their culture is driving so much of what they're doing naturally that when you try to pull those best practices out of those organizations, the things that they feel are 2 or 3 things they're doing specifically to improve HCAPs, it feels like 30 things to everyone else. because their culture's taking care of those other 27 things naturally. And you're trying to pluck some of that out and drop it into a culture that's not set up or doesn't have the foundation for that. What we're going to share with you today is a very specific way to address some of this. In other words, we find that we often end up with this type of a graphic. We have strategy and culture in front of us, and there's a complete imbalance in that we're spending almost all of our time in that strategy bucket, when in fact we all recognize, and you saw that with the numbers that you just put on there, that the culture bucket's actually the big opportunity, especially when it comes to the patient experience and driving some of these other things that we need to produce in our facilities. So this idea of getting more balanced, getting out of that bucket of strategy, and by the way, it's not ignoring strategy. You need strategy. We're not suggesting that you should abandon strategy. We're suggesting there's a balance between strategy and culture, and that's what we need to strike. Now, to do that, we're going to introduce 3 specific principles today, and one of them, we're going to give some description of what we mean by this language above the line. But the first one is we've got to move the culture of our entire facility above the line. Russ, why don't you take us through what that really looks like and what that means?
Well, and you're seeing on your screen this model. This is one of the core models that we use with the hospitals that our change management firm is partnering with around the country. And basically, for those of you who haven't seen this model before, there are 2 parts to it divided in the middle by the line. The line represents engagement. Above the line is where you see people who are taking initiative. They're finding ways to focus on the results that we're trying to achieve. They're focused on removing obstacles. They take the steps to see it, own it, solve it, and do it. Below the line is where you find people who are coming up with all the reasons. We've all worked with people like this, right? You may have some of them on your staff right now. They may be on your unit or floor. These are the people that are focused on all the reasons why we can't achieve higher HCAHPS, why we can't achieve the quality of care that we're looking for, whatever the issues might be. They're paralyzed, if you will, by them. And as Jared and I and the members of our hospital practice team spend several days each week in hospitals, sometimes we even see below the line behavior institutionalized. There are reasons, excuses that people have come up with and that have existed on our units or in our hospital for years that are excusing, giving people a reason and opportunity to opt out for trying to achieve the results. And on this model, you guys, above the line, below the line, we love that language because it's simple. It speaks to accountability. The organizations that we partner with, that language spreads very quickly. People talk about, we need to get above the line on this. And there is a definite difference in the culture of an organization, a hospital, where people are above the line trying to accomplish, trying to work around obstacles, and organizations where people are below the line. And just think about the organizations you interact with. So whether it's a hospital, an airline, a restaurant, a store that you shop in, you can get a sense of whether people on the team that works in that organization operate above or below the line very quickly, can't you? I mean, one interaction with somebody at an airline, and you've got a decent feel for what that culture is like. Whether people around there are quick to go below the line or get above the line, you get the same thing walking to a restaurant or a store. You can just watch people's body language, the things they say. So the culture of our hospitals, the patients pick up on that very quickly on whether or not our people are operating above the line or below the line. We want to have a little fun with this model too, and so below the line you find what we call the blame game. These are all the reasons that people come up with for, in this instance, today we'll talk about higher HCAHPS scores. And you can see the different categories of the blame game here below the line. Jared and I will have a little fun with what we tend to hear people say in different hospitals, and you can think there in your office or wherever you're participating in this webinar today of what you might hear people on your unit or in your hospital say for the reasons why we can't get, let's just say in this case, nurse leader rounding, and higher HCAHPS scores. So on HCAHPS scores, ignore denied, Jared, we might hear people say, I don't even know what HCAHPS scores are. Oh, do we have a goal on that? Is there a target we're trying to hit?
Yeah, how does that work? That's the one that we hit the most there. It's not my job. Hey, look at my unit. We're cranking. We're nailing it. Our unit's doing great with our patient experience. finger pointing, it's that other unit, right? It's that other group. It's the doctors. If the doctors just got this right, we wouldn't have this problem. Confusion, the survey is confusing, or if the N is too small, or all kinds of stuff there. Cover your tail. We've been moving the needle on this for 4 months. We're trending in the right direction, but you still may be completely missing it. Or wait and see, hey, you know what, we've got 3 initiatives going on right now. Just wait till we get leader rounding in place. Once that's really in place, we'll see all these things move. Or just wait until we get the next sequence of initiatives done, and then or wait till we get the right people hired. Staffing's really the problem here. If we get staffing right, we'll be okay. All of those below the line categories, in fact, it'd be great, Russ, maybe we should share the example we just had a couple weeks ago. Within the last couple of weeks, we went on site to 2 fairly good-sized hospitals, 300 to 500 bed hospitals. We've been working with them for a little while on some of these concepts. And as we went back in, we interviewed 40 frontline staff at each facility. And they've got this language, above the line, below the line. They've been using this language. But what we found was, to Russ's point on these stories can be so institutionalized. The staffing story had become so institutionalized as an excuse for why they couldn't move their HCAHPS scores that they would say, hey, we got to get above the line, but in reality, they allowed staffing to become the narrative in the organization. And we had one nurse, we asked her, so take staffing off the table. You got staffing taken care of, it's perfect. What else can you do to improve HCAHPS scores beyond that? And her response was, I don't know, I just always say staffing when someone asks about HCAHPS. And it was so telling that we have allowed that narrative in this particular organization to take over, that everyone's just using it now. And if you think about the danger of an excuse is a noun and a verb. I have my excuse. I'm now excused from having to work on that anymore. So if you allow that narrative to go below the line in your facility, or on your team even, or on your unit, or in your part of the organization, whether you're in ambulatory service care or ambulatory services, or whether you're in environmental services, or whether you're in dietary, whatever part of the organization, if you allow one of those below the line narratives to take over, then people actually disengage. They stop working toward the solution, which is actually a huge problem. So if you go back to looking at this entire model, that line right there really is the line of engagement. When people make a choice to move above the line, they're choosing to engage and follow the steps above the line, which is see it, own it, solve it, do it. In fact, if you take those steps and go a little deeper into those, see it, there's a key question here for see it, which is, what's the reality I most need to acknowledge? If you take that staffing issue, for example, if that's the answer, that we've been short-staffed for years and it's probably never going to be perfect and we're always going to have some staffing issues, well, if that's the reality we have to acknowledge, well, then what's Own It look like from there? What do we do next to actually engage at a different level? And the Own It question is, well, how am I contributing to the problem and or the solution? In other words, how am I involved? And what's my involvement need to look like? We've actually found that there's different levels of ownership. I think you would all agree with that. I mean, if you ever rented a car, do you drive a rental car differently than you drive your own car? The answer is yes, right? You do things very differently in a rental car. Well, why do you do that? Because you have different levels of ownership. And so to kind of define this, we're going to show you this levels of ownership model. It kind of plays out, why do you have people taking the level of ownership they're currently taking? And we're going to use rounding for an example here. Let's say we've put rounding out there. We want everyone to be doing leader rounding. We want all of our leaders rounding on patients. So you're going to have some people at the disagree, uninvolved stage of this. I don't think this leader rounding is going to make a difference. And by the way, I shouldn't be doing it. It's really somebody else who should be doing it. I'm not really involved. So that's the resist, resent level of ownership. That level of ownership is, I don't see the point and I'm not going to do it. And I'm actually upset that you're even bringing it up to me. The next level of ownership is agree but uninvolved. This is the group that says, oh yeah, that's exactly what we should be doing. Leader rounding, that's where we should be, but I'm special. I'm unique. I'm exempt. I'm excused from having to be involved in that for whatever reason you want to throw it out there. The next one, in other words, I'm going to get my light duty nurse to go do that while I'm doing paperwork or I'm making discharge calls or whatever else I'm doing. But that agree but uninvolved is a really interesting one. We can talk more about that here in just a minute. The next level of ownership is the disagree but involved. We call this the comply concede group. This is the group that takes the rounding tool, the iPad home on the weekend and fills out all the rounds for the whole week to comply and concede and check the box and show that we've done it. I disagree that this is really useful, but I'm going to do something here, so I'm somewhat involved. The highest level of ownership is I totally agree, I'm involved, I'm bought in, I'm invested in making this happen. This is the group that makes time to do leader rounding and sees it as a way to engage patients and manage the unit and really drive the patient satisfaction experience throughout our hospital. So these levels of ownership, I would be willing to bet that you guys, if you looked at your own facilities, you would see different people at different levels of ownership across the board. I would actually like to do another poll here on this. So if you take those levels of ownership into consideration, where would you put your hospital's expanded leadership team, your administration, your directors, your managers, so the expanded leadership group of your hospital? Where would you put them on the levels of ownership regarding leader rounding? So let's open that poll up, Jenny. We're making an assumption here, obviously, that you're working on leader rounding. We think that's a fairly safe assumption because we know from our experience that a lot of hospitals are working on this right now. But we'd love to hear where you're at on this as everyone who's on this call. So, Jenny, let's open up that poll.
So, Jared, let me just a thought here. You know, there's a major difference, you guys, in the hospitals that we work in the level of ownership. We spend a good deal of time with the organizations that we're partnering with talking about this issue of ownership. And so below the line, you have people coming up with all the reasons why leader rounding isn't important, why we can't get higher HCAHPS. I mean, think about all the excuses you hear in units and different units and floors of hospitals of, well, the way that they survey is just foolish. I mean, it's not an accurate number. There's not a large enough sample size. Staffing, you know, Jared's talked about staffing, and you guys, anyone that's worked in healthcare for more than 6 days or 6 months knows that staffing has always been an issue. We haven't walked into a hospital anywhere in America yet where people don't tell us we have a staffing issue. We need more nurses. We can't retain. I mean, it's an issue everywhere, and it's a legitimate issue. But there's a difference in the level of ownership when we say, yeah, we're working on staffing and we take ownership of higher HCAHPS. I think we've got the poll up there now. So if you want to look at that, we've got the levels of ownership defined there on the right side of your screen. You can see what resist, resent looks like, exempt, excuse, comply, concede, buy in and invest. So take a minute to evaluate what you're seeing in your hospital, and then click on the level of ownership that you see most often. And again, if you're watching this webinar in a group, you might have just a brief discussion and agree on which one you guys see most often, and then click on that. So we'll give you a minute to vote on which level of ownership you're seeing with your expanded leadership team on leader rounding.
All right. I think we've closed that. Let's see what the numbers look like. And as we're waiting for those numbers to come in, you'll notice on this levels of ownership, the words agree, involved, disagree, uninvolved. The two levers that really move ownership is agreement and involvement. So if you've got a group that's sitting at exempt, excused, well, then you know you've got to pull the involvement lever. You got to get them more involved. So that's actually really interesting. The numbers come out almost evenly split between the top three layers there. So let's talk about that comply concede group for a minute. That's a dangerous part of the organization. We've got 38% of us saying we've got our leaders that comply concede. They disagree, but they're doing something about it. So the problem is if they ever see their involvement gone, they don't just drop to exempt excuse, they drop to resist resent because they already disagree. So if their involvement disappears, they drop all the way to the bottom. The exempt excused group is actually an opportunity because they do agree. You just got to get their involvement to show up. And if you can move their involvement up, then you get them to jump up to bought and invested because they already agree with it. So it's getting them to see that their involvement is critical or an important piece of that. and you drive a very different level of ownership with that. So this own it step, so see it as the first step above the line, own it is the second step above the line, solve it is the third step above the line. And this question, what else can I do, is the number one best question to be asking for Solve It. Notice it is not what more can I do. You guys are already full of stuff. Everyone is. In hospitals, we've got initiative fatigue. We've got more on our plates than we could possibly ever accomplish. And so in a lot of cases, we're not asking to do more. We're asking what could we do differently? And what else can I do? And constantly asking that question will drive that in a very unique way. And lastly, the last step above the line is do it. And do it is who will do what by when. If you don't have who and by when, you don't really have a plan. And so getting to the who will do what by when piece becomes really important. So the way we got into this is we talked about fixing the patient experience, 3 principles. The first one is get the culture above the line. Get the culture to truly see it, own it, solve it, do it, to engage up there about HCAHPS and driving that. The second principle is to identify and reorient belief bias. Now, we're going to dig into belief bias here and give you a sense of what that means. Russ, why don't you take us through what it looks like let's take us through the results pyramid real quick.
Gotcha. Yeah. So the first core model that we use with the hospitals that are partnering with us is the steps to accountability model, the one that we've just spent some time with you working on, and getting above the line and below the line, and having directors and administrators in hospitals really evaluate their teams and look at, okay, is my team above or below the line on HCAHPS scores, quality, whatever the result is that we're looking for. So that's the first core model. The second core model that we work with organizations on is the one that you're seeing on your screen right now. And again, some of you have been on these webinars before, so this will look familiar to you. This is brand new. And the results pyramid, this core model starts at the very top with the results. These are the results that we're trying to achieve. In this case, as we're talking about today, it would be higher HCAHPS scores. And the way we obtain those results is through the actions that people are taking. So one of those actions, as we've been discussing, is nurse leader rounding. And whether that's something, if you're part of a large hospital chain that's where it's the system that's asking nurse leaders to round, or whether it's you're an independent hospital and as an administration, or you as the CNO or the CNO of the hospital is asking us to do that, we're being asked to take specific actions to affect that result. Now, how we approach those actions and whether or not we actually do them is all dependent on our belief. And do we believe that if we believe that nurse leader rounding affects HCAHPS, that it affects a patient's experience, and that it can affect employee engagement, I want to talk more about that in just a second, then you see a very different type of nurse leader rounding. You see different levels of it as far as how frequently it's done, how the nurse leader approaches it, whether or not it's really impactful. You see that if there's a belief about it. If the belief is this isn't important and it's just a check the box, you see a check the box mentality, then nurse leader rounding is done in a whole different way. And the beliefs that we have are driven entirely by the experiences that we hold. So as you look at this model, the way to read this or think about it is the experiences that we've all had have led to beliefs. The beliefs that we hold drive the actions we take. There's not a single action that anyone takes tied to HCAHPS or really anything in life. There's no action anybody takes that isn't driven by a belief that they hold.
And importantly to note on that, some beliefs are more entrenched than others, right? Whether you show up on time to a meeting or not, or whether you have deeply held beliefs around your children or something. I mean, there's different levels of beliefs, and the beliefs that we're talking about here and today are why are people doing what they're doing in your hospital? And when you look at this model, where do most people go? When we're not getting the result that we want, right? When we're not getting this result, where do we typically go on this model? What we typically find is people go right to the action layer. And the action layer, you have this plane that goes right in the middle where you end up with what we call the leadership trap. The leadership trap is that we spend all of our time on the top 2 layers of the pyramid. We put new policies, procedures, all these different things, checklists in place, and it creates this action approach, trying to drive results. The reality, though, is there's beliefs and experiences that are driving all of those actions. And we're ignoring the fact that people actually think that people actually hold beliefs. And when people hold beliefs and we don't assess or address those beliefs, we end up throwing mud at the wall at the action layer and hoping we get something to change, when in reality we're not truly getting that change to take place. There's lots of examples of this. One example is an emergency department that we were working with, where this organization, this leader of this department, said, I need to get emergency contact information more effectively. Right now we're only getting it 42% of the time. We said, okay, well, what'd you do? She said, well, I put we have these forms to get in to when you're brought into the emergency department to fill them out, these mission forms. There's too many of them. They're complicated. So I got it down to one page. We said, great. Then she said, I also got it translated into 6 different languages so that we could just hand the one pager to someone in their own language. Great. And I also trained people. I trained 120 people on how to use the form and how to do the admitting process more effectively. Great. So if you look at this and you were to ask what layer of the pyramid has she been working on up to this point, you would say the action layer. She rewrote the form. She trained everyone on the form. She got it translated in different languages. So we asked her, so what's the result? How are you doing on this? Her head dropped and she sighed and said, we've gone from 42% to 47%. She wanted 100%, but she got a measly little bump. Now, we're going to ask you guys on this call the same question that we asked her as she was describing this to us. If they're only getting the information 42% of the time, what is their belief about that information? It's not useful, not needed, exactly. So as you're thinking through that, we know that's the answer that she was giving, right? She said they don't think it's needed. They don't think it's useful. So what do you have to do to change a belief? If you look at the model, the only way you change a belief is by changing the experience. Have you ever had someone tell you I'm going to be different from now on? How's that working for everybody? It doesn't work. The first thing you say is, well, that's great, but show me. Show up different. In this case, she found some experiences that she could use and tell through the medium of a story. These were real experiences that occurred in their hospital that she used to shift the thinking on this. One was there was a college student who got hit by a car. She got brought into the emergency department. They got her next of kin information, her emergency contact, or they didn't get her emergency contact information, I'm sorry. She became unconscious, unresponsive. They tried a bunch of different things to get her back. Nothing worked. They lost her. They found out later she had a medical condition that they were completely unaware of. That had they been aware of it, it would have altered their treatment for her. Now, it may not have ultimately changed the outcome, but it could have changed and increased her chances of survival greatly had they known that piece of information. Second story, same hospital, different time. There was an older gentleman brought into the emergency department. They were treating him. They did get his next of kin information, his emergency contact. While they were treating him, he became unconscious. They called his daughter, whose information they'd given him, or she'd given him, or he had given her, sorry, and they called his daughter and said, here's the medical history we have for your father. Is there anything missing on this list that you know about that we don't? She said, well, yeah, he had a procedure 3 weeks ago. Do you know if he's taking any medication for that procedure? She said, yes, he's got a prescription. Do you know what the prescription is? She said, no, but I took him to the pharmacy. I stayed in the car. He went in. He came out with something. I'm sure he's taking something for this. They were able to ascertain what the standard prescriptions would be for the procedure he had. Then looking at what they were giving him and the symptoms he was displaying, they were quickly able to triangulate this and realize that what they were giving him was conflicting with what he was taking. Because they knew what it was, they tried a few things, they worked, they got this guy back, saved his life. She told those 2 stories for the next 3 weeks. She had her staff telling them for the next 3 weeks. They went on a campaign to make sure everyone heard these 2 stories over the next couple of weeks. It just so happened 3 weeks was when the next report came out. So as the next report comes out, she looked at the numbers. They'd gone from 47% to 92% of the time getting next of kin information, emergency contact information, in 3 weeks. So guys, do we ever overcomplicate the action layer, trying to compensate for a belief layer problem? This example is classic. We do it all the time. We call it actionitis. We go right to that action layer and we try to create all the actions that we need people to take to get the result, when in reality, in a lot of cases, we've got beliefs working against us. And this sets up the case for why we need culture change. And you guys, you can look at culture in a lot of ways. Do your teams have a culture? Does your unit have a culture? Does your staff, your direct reports, your peers, do you guys have a culture on your individual team? Absolutely. And working just your team has a huge impact. So some of you could be looking at this and saying, well, I don't have the ability to change my whole hospital right now. I'm just in this one part of the organization. Great. start working your part of the organization. There's things you can be doing right now to drive change right where you're at. And if we can get enough people starting to do that, you'll end up shifting your entire culture. So,
and just to add to that, if you're just working the action layer, you guys, if you're just asking nurses or nurse leaders or whomever it might be to do rounding, but you're working the top of the pyramid, but you're not working the bottom layer of the pyramid, the bottom layers of the pyramid, you're not going to get the change that you're looking for. So that's where we hear hospitals and directors and managers in hospitals say, man, we've been focusing on these things and we're just not able to impact HCAHPS scores the way we want to. It goes to the case for culture change. Your culture might be betraying the actions you're asking people to take. So if you look at some of the bullet points here on your screen, the beliefs that your staff holds, they're driving the actions that people are taking. And so strategy alone, just asking people to do more things. And in the healthcare industry and hospitals, we're fantastic at overcomplicating the action layer. We've always got new initiatives. We've got checklists that are being added to people's plates all the time. That's not going to be enough. Those things are not enough. Just working that action layer where you have to really get the layer you have to get on the pyramid to affect the result you're trying to get is to get down to that belief layer. You've got to get people to change the way they think and act in order to bring about the change that you're looking for in HCAHPS or whatever it might be, the measurement that you're looking for.
Yeah, and that's well said, Russ. So group, today, as we think through this, there's two core models we've introduced to you, the steps to accountability and the results pyramid. The takeaway that we want you to have is, how do you start doing something right now on your team? How do you really engage? Now, we're happy to help you engage too. If you're looking for our help and you want a phone call or additional, we're going to give you an ebook coming out of this webinar that you can share. You're going to get the recording of this webinar that you can share. But we're looking to help you make the case for why your team can be different. The beauty of this model, the results pyramid, is it informs people as to why we're doing it the way we're currently doing it. And as people understand why, we've had experiences that lead to beliefs. If they understand that, then that opens up the ability to do it different. We can actually change the way we're functioning on this. And the steps to accountability, above the line, below the line, see it, own it, solve it, do it. How do we get people to recognize that I need to engage at a different level? That is hugely effective. And if we can get that moving, then we've really got a chance to create something unique and different. Now, I'm going to jump ahead a little bit here. And actually, that went a little too far. This last piece on fixing the patient experience, 3 principles. Number 1, we talked about getting the culture above the line. 2, identify and reorient belief bias. What I meant by belief bias, or what we're talking about with belief bias, is that belief layer of the results pyramid. People tend to validate the beliefs they already hold. So if we've got a guy on our team named Rick, and Rick's always late, and everyone knows Rick's late, and Rick shows up on time for the next 90 days, but on day 91 he shows up late, what's everyone saying on day 91? They're saying, there's Rick, he's always late. Why do we do that? He just gave us 90 days worth of data saying he's always on time. Because the belief we already hold about Rick is he's always late. So we focus and look for day 91. We're not looking for days 1 through 90. So your patients are walking in the door. They've got beliefs about your hospital, and they're looking to validate those beliefs. And so the ability to identify and reorient belief bias in your patients, your staff, it's using that results pyramid to understand what are the beliefs and how do we create different experiences to address those beliefs specifically. And there's very specific tools to do that. And then lastly, it's train, retain, and sustain. And what train, retain, sustain is all about is how do you actually drive the specific experiences throughout your team and your organization as a leader, as a peer, as an individual contributor to drive the shift that we need to see in our organization, and be very specific around how to do that. So as we wrap up our call here, we want to get into what it takes to create really critical mass. The more people you get involved in making a change, the faster and the more critical mass, the longer term you're going to create that sustainable change. In your own teams, that can happen very small. It can happen with the entire facility. We would suggest start with your own team. And as you start with your own team, we like to say it this way, either you manage your culture or your culture will manage you. And that's subcultures, that's cultures within a team, but getting really clear on how to create the right experiences to drive the right beliefs to get the right actions to take place. Culture is basically how do people think and act when you're not standing over their shoulder. And if you can get people to think and act the way you need them to when you're not sitting right next to them, now you've got a culture that's creating a competitive advantage for you in lots of different ways. So next steps. We've done some research on this. We know a lot of you are going to say, I love what I heard today. I'd like to do more with it, but I don't really know what to do next. Well, what to do next is there's a lot of things you can do next. One is just call us. We're happy to talk with you and help you with this. Whether it's a team of 2 or 3 or 4 or 8 or 30 or 40 or 500 or 7,000, we can work with you on any one of those groups. We've got lots of examples of organizations that we've worked with to help drive these exact changes and get better HCAHPS scores. And we can speak to 10 months in, 20-point, 30-point moves and jumps forward on HCAHPS with multiple facilities. Maybe really quickly, Russ. Actually, you guys, I don't know. Tell real quick about Athens. Let's hear just a little bit about that story.
Yeah, you know, it's interesting to see the different obstacles that hospitals face. Some of them are common, like the staffing issue we've talked about. That's something that most hospitals are dealing with. Others are unique. And with one particular hospital that we wanted to highlight today, it's located in the southeast United States, in the suburbs of Atlanta. This is a hospital that has difficulty recruiting talent because of it's in a smaller market. When we got engaged on the project with them, the hospital was millions and millions of dollars in the hole. HCAHPS scores were low as well. And there clearly needed to be a culture change. And the nurse leaders and frontline staff at this hospital all would talk about the way things used to be. In fact, we hear that a lot, don't we, Jared, in hospitals, the golden years, how it used to be. And you know, in some places there's truth to that, but we have to be careful to not go below the line on that and excuse the accountability each of us has to make it as good as it used to be. So this particular hospital, they got to work on making the culture better, and dramatic results on HCAHPS financials. That hospital right now in 2016 is seeing a net profit of over $1 million a year, and they were per month. Excuse me, over $1 million of profit per month. In the past, they would have been happy with $1 million of profit. They would have. But now it's $1 million a month, and
we know some of you guys are nonprofit and faith-based organizations, so we're not suggesting it's all about the numbers. We know it's about the patient experience, but it's important to recognize that they had significant shifts. They were about to go out of business.
Well, and the real story here, Jared, is that yes, the financial measurements improved, but those also improved while patient experience improved.
That's right.
And so it wasn't just, well, it's all about the money, and yeah, we're getting more money in the front door, but look what we're doing to our patient, the quality of care. No, in fact, what happened was engagement scores are increasing of employees, which were in the tank, and HCAHPS are not only improving, but they're seeing sustained levels. So how does that happen, right? It's all about, we showed you the model of levels of ownership earlier, and it's all about culture changes, you guys, at the unit level. It changes with each nurse leader. It changes with each team. It changes one person at a time, getting people above the line and taking ownership and saying, okay, we can impact the patient experience. What can we do about it? While acknowledging some of the challenges we're dealing with, but getting above the line and taking ownership and shifting the beliefs we hold about one another. In fact, in that hospital, there were all kinds of silos. This unit had negative feelings about that unit, and okay, our HCAHPS would improve if only those people over there would get their act together. So how do you knock down silos, get teams communicating one with another, and individuals taking accountability for the patient experience? That's what these two core models really speak to, and what we've been trying to focus you on today. And you don't have to have, if you're just responsible for one unit or one team, it doesn't mean you have to wait for system-wide engagement on this. You can do it just by yourself. And what Jared's saying too, we are totally open, you guys, to speak. We have individual unit leaders who are engaging us. Just phone calls about, hey, how can I improve my huddles? How can I improve this, that, or the other? We're happy to engage at any level and get you whatever we can, speak to our experience to help you achieve the results you're looking for.
So this ebook that you see on the screen right now, you're going to get pulled right to this when you log off today's call, and you're going to be able to download this ebook. And it'll review a lot of the data that we've shown you today. It'll also give you some of the talking points that we've talked to today. And as an ebook, it's something you can easily share and create awareness if you would like to do that. So we would be happy to help you with that as well. So Jenny, let's take some questions. We don't need to go through a lot of questions. If there's a few that we can answer quickly, let's take a few minutes and do that.
Sure, Jared. I do have a question here from Leah. She asks, what have you done when there's a need for change, but senior leadership won't acknowledge there's an issue?
Yeah, that's a great question. And what we have found is the see it step above the line is the most important step. And there are some best practices around see it. And getting leaders to see it has to do with feedback. It has to do with other people's perspectives. There's a way to gather up that information, but it's got to be linked to the results of the organization. So making the connection between the feedback and the observations that you're gathering up and the impact that it's having on the actual results is critical to all senior executive groups. They need to be able to make the connection on how it's impacting the performance of the organization, or you're not going to see a ton of movement from that group, from my experience. But that's how you do that. And we're actually really good at coming in and working with you in pockets of the organization to help to develop that story and then present that to the senior leadership team in a compelling way that gets them to start thinking differently. Other questions?
Great, thank you. I do have a question from Steve. He asks, where do people usually start with this process, especially when it feels like an overwhelming task?
Russ, you want to take that?
Yeah, it goes to what we were just talking about, Steve, which is that you don't have to wait for we talked about culture, and yeah, that's best. That is often a hospital-wide issue, right? But if you're working at the director level or manager level, you just start working on your culture. And the two questions, that you could ask is, what are we below the line on? Where are we below the line right now? And what do we need to do to get above the line? Who on my unit right now, which members of my staff are operating below the line, and how can I help them? And sometimes you guys, we get this question all the time. Aren't there some people who just will never get above the line? And the reality is, yeah, that is the case. There are some people who are so entrenched below the line, coming up with all kinds of excuses for everything, that they're never going to get above the line. And with those people, then you just have to look and decide whether or not you can afford to have them on your team and invite them, in many cases, to exit. But other people who are below the line aren't even aware of it. And they may be part of a team where below the line behavior is so common, so frequent, it's just how we do things around here, that they don't see it. And so the first step we would tell you is model the behavior, Steve. Model above the line behavior, because when leaders go below the line, they give license to everybody else to go below the line. And when you go above the line, when you respond to challenges, when you're talking about HCAP scores or leader rounding in an above the line way, people model that behavior. They think about. We were just in a hospital, Jared and I, with other members of our hospital practice team back east. 2 weeks ago, and we were interviewing. Jared spoke to this process we go through often of interviewing frontline nurses, and we had and staff members. We had 40 people in this particular hospital that we interviewed, and we asked them about leader rounding. Now we're talking to frontline nurses and other people, everyone from nutrition, you name the department. We were interviewing them. We asked them about leader rounding. They were actually selling the value of nurse leader rounding to us, acting as if we needed to be convinced about it, because we were playing dumb and just asking open-ended questions. And they saw two dramatic effects of it, two great impacts of nurse leader rounding. Number one, they outlined to us was it's leading to better quality care. The patients on our floor and our units are getting better care because there are things sometimes that people miss, and the nurse leaders are picking up on it. Number two, it's leading to better employee engagement. They didn't word it exactly this way, but that's what they were saying. And the reason they felt like it was leading to better employee engagement was because these particular directors, these nurse leaders, had created an experience for individuals in those units that led to a belief that, you know what, Our nurse leaders are going into patient rooms and listening for names of who on the staff is impacting patient care. And then they're publicizing that. They're telling stories about it. They're recognizing it in a genuine, authentic way. And so they saw it as impacting those two areas. So to the question, where do you start? Work on getting people above the line and identifying where you're below the line. Second, think about the beliefs that exist on your team and what beliefs might be getting in the way of the results we're trying to achieve. And then give people the experiences that are needed in order to shift those beliefs. Great question.
All right.
Thank you. Sorry, Jared. Do you mind if I have just a couple more? People are pretty interested with some questions here, if that's okay.
Yeah.
I hope I pronounced this correctly, but Elise asks, what is the best way to handle the us versus them mentality between departments when it does negatively impact HCAHPS scores? Great question.
Getting people to understand the key results, the results that we most need to achieve throughout the entire organization is a really important thing. You've got to get to the why. And everyone's going to say the patient is most important. No one's going to vocally say that it's not. What we find is the actual belief people have, though, is not that it's all about the patient. The experience that's being created in organizations is what's more important is that you do all the things they've asked you to do on your checklist. And the most important thing is that you take care of all these tasks or these other initiatives that we've given you, and the patient actually does get lost. Even though we say it's the patient, we don't actually link it back to the patient. And that's the experience that people are having. And when you have that experience, then their belief is, well, I've got to do all these other things. They're more important. And so people are not taking action by accident. They're all taking the actions they're taking because they've had some experience that's led to a belief, and that belief is now driving that. So the only way you interrupt that process is you've got to get at their belief. You've got to create a different experience for them to help them see that this is an important outcome to the patient and draw it all the way back to that strongly, compelling, in a compelling way that makes sense to them, that lands for them. Stories are really important in that process. It gives people a visual. It helps them understand the impact. Stories are 22 times more memorable than data. All the research shows that they're that much more memorable than data. And you got to use those at the experience layer to get people to move. What other questions do we have, Jenny?
I have one more I think we have time for here from Diana, and she asks, what's the best way to back beliefs with experiences?
Good question. Let me take that one. The way to really lead a team using the results pyramid and make sure that you're leading using the bottom layers, the bottom two layers of the pyramid, which are experiences and beliefs, is to ask a couple of questions. There are tons of great questions that the results pyramid generates. A few of them would be, what beliefs does my team hold that are getting in the way? So what beliefs does my team hold right now that are getting in the way of us achieving the results we're trying to achieve? And so you give some thought to that, and a great way of finding out, you're going to know what some of those are already. But then as you go out and really listen and ask some key questions and get feedback from members of your team, those will become very clear. And then the question becomes, well, which one of those beliefs do I not want them to hold? And you go to create experiences. You're very deliberate and intentional in designing experiences that are going to shift those particular beliefs. Another question that's great to ask as a leader, we work with nurse leaders and directors in hospitals all the time on asking these questions, and that is, what beliefs, this gets to a more personal level, you guys, but it speaks to leadership development. And what we find a lot in hospitals is people have been elevated into director positions in hospitals without a lot of leadership training. And so they're not quite sure how to lead people. And, Jared and I talk about culture and how important that is. Well, I've never received training as a director and how to affect culture inside my team. And, well, what we're talking about today really will impact it. And so one question that you would ask around beliefs and experiences, too, would be, what beliefs do the members of my team hold about me? And which one of those beliefs do I not want them to hold? And so, again, you identify those, you're very thoughtful about it, and then you go to work on creating experiences that are going to shift those beliefs about the members of your team? Or, you know, if you're a nurse director, what does the CNO believe about me? What beliefs does she hold about me? Or different members of the O team, what beliefs might they hold? And we go to work on it. But what we found is that when you're working the bottom two layers of the pyramid, you're asking the questions about what beliefs people hold and giving them new experiences to create the right beliefs. You don't have to micromanage, because now nurses, different members of the hospital team, the different members of the staff, they're self-selecting the actions you want them to take. When you're not working the bottom two layers of the pyramid, you're exhausted. You're dead tired, because you're giving it everything you have to try to get the right results. And people just aren't doing what you need them to do. You go home after a 14-hour day and you're staying late every day and the HCAHPS scores aren't freaking moving, right? You can't get them where you need to go, where they need to be. And you're feeling the pressure from upper levels of the leadership team of how do I get them where we need to go? Well, you've got beliefs that are working against you. And you're not going to get people to self-select the right actions unless you work that belief layer. So it's a great question, Diana. Thanks.
Great. Thanks, Jared and Russ, and thanks to everyone for attending today. As you all log out, you're going to be directed to a web page where you can download our free ebook that Jared and Russ were talking about earlier on sustaining higher HCAHPS scores, so you can keep this conversation going back at your hospital. So again, we'd like to thank you for joining us today, and this concludes today's presentation.